In this session, which is supposed to be the first session of the head and neck, we are going to describe the anatomy of the scalp and the face, the muscles found, the nerves, and the blood supply of each. Let's start by the scalp. The scalp, the part which covers the vault of the skull, extending from the superciliary arches anteriorly to the highest nuchal line posteriorly. On each side, the superior temporal line. These are the boundaries of the area which we call it the scalp. The layers of this scalp are 5 layers. Usually, it is said it can be defined by the same name of the scalp, SCALP. The first layer will be the skin. Second layer will be a connective tissue. Third layer will be a aponeurotic layer, or the aponeurosis of the occipitofrontalis. The fourth layer will be the loose area connective tissue deep to the aponeurosis. And lastly, the periosteum or the pericranium on the outer surface of the skull bones. So the first layer, or the first 3 layers actually, are very tightly connected together by the connective tissue in between the skin and the aponeurosis, forming a single unit can be moved on the periosteum by the loose area connective tissue. This tissue is torn away during serious scalping injuries. The 3 layers can torn away together during any accidents or fighting or whatever. These 3 layers will be cut or avulsed as 1 layer. The first layer, the skin, is hairy with very numerous sebaceous and sweat glands, a good number of them. Obstruction of the ducts of these glands will lead to the formation of what we call it sebaceous cysts. They move with the scalp. Those cysts move with the scalp, being between the 3 layers, which are 1 layer. The connective tissue is the tough layer of connective tissue attaching the skin to the underlying aponeurosis. This attachment by a fibrous bands between the skin and the aponeurosis, converting this space into some locules which have some fat within and connecting the 3 layers together. It has the richest cutaneous blood supply in the whole body. That's why any injury to that area, the bleeding is too much. The third layer is the aponeurotic layer, the epicranial aponeurosis, a tendinous band or sheet which connects the frontalis muscle with the occipitalis parts of the occipitofrontalis. On each side, laterally, is attached to the temporal fascia. The fourth layer, the loose areolar connective tissue, is found in subaponeurotic space and contains few arteries and some important emissary veins which connect the veins outside the skull with the veins inside the skull. It has a role which will be described later. Bleeding in that area, in that region here, will form a hematoma which can move to the sides, or it can dribble the blood down in the front to the upper eyelids, forming what we call the black eye, because this layer is continuous with the subcutaneous layer of the eyelids. So the injury is up in the scalp, but it appears as a black eye. The pericranium, which is the periosteum on the outer surface of the skull bones, is the deepest layer, and it is the periosteum, as you said, of the outer surface of the clavera. And the sutures, this periosteum or pericranium will go through the sutures to be attached to the periosteum on the inner surface of the bones, what we call it the endosteal layer. The muscle which we call it the occipitofrontalis, the only muscle which forms the epicranial aponeurosis, is formed of two parts: occipitalis muscle, this part here, which take origin from the highest nuchal line and got inserted into the epicranial aponeurosis. The frontalis muscle, the part in front, usually we say it takes origin from the anterior part of the epicranial aponeurosis to be inserted into the skin over the eyebrows. So it ends in the skin over the face to be part of the muscles of expression, like the rest of the muscles of the face. Its action as expression, it throws the forehead into transverse wrinklings, as in expression of surprise or hero. So it belongs to the muscles of the face. All the muscles of the face and the scalp are supplied by the facial nerve. Here is the blood supply. The blood supply of the face comes from the external carotid and the internal carotid arteries into small branches reaching the face. The supratrochlear, this one here, and the supraorbital are branches of the ophthalmic artery, branch of the internal carotid. The rest will be branch of the external carotid. Superficial temporal, the large one here. Those three are in front of the auricle. There is two behind the auricle, which are the posterior auricular and the occipital artery. So there are 5 arteries on each side, meaning 10 arteries are supplying the scalp, which is a very rich blood supply, as we said. That is the occipital artery. The veins will be discussed with the face. For the nerve supply of the scalp, it comes as sensory supply from two main sources: the trigeminal nerve and the cervical nerves, second and third. Motor from the facial nerve. In front of the auricle, there is the supratrochlear and the supraorbital nerves. Both of them are branches of the ophthalmic division of trigeminal. And the zygomatico-temporal branch of the maxillary division. The auriculotemporal, a branch of the mandibular division. With them, the temporal branch of the facial nerve, which is not shown here. So there are 5 in front of the auricle, and there is 5 behind the auricle. The great auricular from the second and third, the lesser occipital, the same. These 2 nerves arise from the ventral rami, the cervical plexus, while the greater occipital from the second and the third occipital from the third cervical, both of them are from the dorsal divisions of the spinal nerves, with a branch from the facial nerve, which is the posterior auricular nerve, and this for the muscles of the ear and the occipital belly of the occipitofrontalis muscle. Now to the face. The facial muscles have some characters which are different from the rest of the muscles of the body. Being muscles of expression, they have to be connected to the dermis of the skin. They are very thin and flat muscles. The expression is done by the skin of your face, all the expressions. So those muscles should be attached to the skin. They are innervated by the facial nerve, as we said, all the muscles. There is considerable individual variations in those muscles, in the shape, in the thickness, in the position, or even of the existence. They often blend into each other. Being very small muscle, they can blend together. There is what we call it the relaxed skin tension lines in the face, are well-known lines for a plastic surgeon to go through the incision through them, and those lines are perpendicular in harmony with the direction of the muscle fibers, which is very important. Those muscles are almost around 26 pairs of muscles. What we need to know in details are three muscles only: the buccinator muscle, the orbicularis oculi muscle, and the orbicularis oris. And we'll know the names and the action of the other muscles in tables in a summary. Let's start by the buccinator muscle, which found on each side of the mouth opening. That muscle originates by three fibers: upper fibers from the maxilla above the three molar teeth, lower fibers from the oblique line of the mandible, which is also lower below the lower three molars, and a middle fibers from the trigomandibular raphe, which is attached between the pterygoid hamulus of the sphenoid bone to the mandible and the posterior part of the mylohyoid line. So it extends in a line between the skull and the mandible, the trigomandibular raphe. The word raphe means meeting of two muscles. So that buccinator muscle arises in common through that trigomandibular raphe with the superior constrictor muscle of the pharynx. That's why the fascia covering the buccinator will extend on the surface of the superior constrictor to be named, or the name given is buccopharyngeal fascia, on the buccinator and the pharynx. These are the three types of origin. The insertion, the upper fibers go directly to the upper lip, while the lower fibers will go directly to the lower lip. It is the middle fibers which decussate at the angle of the mouth. Being aligned like that, the upper fibers will go to the lower fibers, to the lower lip. So the upper fibers going to the lower lip, while the lower fibers will go to the upper lip, decussating at the angle of the mouth. In certain individuals, you can see elevation of this crossing on the sides of the mouth orifice. So the lower fibers go to the upper lip. The action of this muscle is very important to remember and to know, because it is the key to diagnose the facial nerve injury. It is a muscle which compresses the cheek against the teeth and gums during mastication. By pressing against the teeth and the gum, it prevents accumulation of food and saliva in the vestibule of the mouth. It assists the tongue in directing the food between the teeth. It's the important muscle of blowing, suckling, kissing, and whistling. More important, it keeps the mouth orifice in the middle line by equal pull of the two muscles on the mouth orifice. If there is an injury of the facial nerve and there is paralysis of the right side, the left side of the mouth will be deviated by pulling to the left by the healthy muscle on the left side. A patient with facial nerve paralysis will have dribbling of saliva on the side of the mouth because the first action, no compression on the teeth. He cannot blow, he cannot whistle. That is the deviation of the mouth. These are the features of nerve paralysis of the facial nerve. Second muscle is the orbicularis oculi muscle. That muscle over here, the orbit, it forms a circle around the orbit. It's formed of three parts: orbital part, this part here around the outer part of the eye. It takes origin, this part, from the nasal side of the frontal bone and the frontal brows of the maxilla and the median or medial palpebral ligament. The two eyelids are fixed together by a medial and lateral palpebral ligaments. So that orbital part takes origin from these three parts: the nasal side of the frontal bone, the frontal brows of the maxilla, and the medial palpebral ligament. The fibers will form a complete circle around the eye without any bony attachment on the lateral side. It may be connected to the skin, forming some corrugation on the lateral side, and come back to the point of origin. The action of that part is forced closure of the eye or squeezing the eye. The palpebral part, which is found in upper and lower eyelids, this is the palpebral part here, arise from the medial palpebral ligament to be inserted, and the bones around it to be inserted into the lateral palpebral ligament. So it comes from the medial to the lateral palpebral ligament. Its action is gentle closure of the eye. The last one is the lacrimal part. And the lacrimal part is found in the, or takes origin from the upper part of the lacrimal crest. During study of the skull, on the medial wall, there is a lacrimal bone, a lacrimal groove for the lacrimal sac, and this groove is bounded by two crests, an anterior one and posterior one, anterior one by the nose, nasal bones, and posterior one by the lacrimal bones. So it takes from the lacrimal crest and adjacent lateral side of the lacrimal bone. This part will pass laterally behind the sac to end by attaching to the fascia around the sac. Its main action is to pull on the sac, to dilate the sac, to help in suction of the tears to the sac and then to the nose. These are the three parts. The other third one is the orbicularis oris muscle. This muscle here around the mouth orifice in the upper and the lower lips. That muscle arises from the tissue around the mouth, and most of its fibers comes from the buccinator muscle, continuation of the buccinator which passes the upper and the lower lips. It helps in shaping the lips as during speech. That is the orbicularis oris. Now we have a summary of the muscles of the face to know the names, the actions, and the nerve supply. As you said, the nerve supply of all of them is the facial nerve, but each muscle have supply from one of the branches of this facial nerve, which are 5 branches in the face. It's important when you are doing a sort of a plastic surgery here. So the forehead muscles, which we have seen first, the frontalis muscle here, which elevate the eyebrow and take from the temporal branch of the facial. The psoarias muscle here in the middle line, which depresses the eyebrow, takes from the temporal, the zygomatic, and the buccal branches. The corrugator supercilii, which depress the eyebrow by the temporal, the zygomatic, and the buccal. And the orbicularis oculi, which we have seen. The lip muscles are three groups. The first group, the orbicularis oris, which clothe the mouth. By the buccal marginal mandibular, the buccinator muscle, we have seen it. By the buccal, risorius muscle, a small muscle on the side of the mouth, which draws the commissure laterally. By the buccal zygomatic. The levator anguli oris, this small muscle here, which elevates the commissure upwards by the buccal and zygomatic. The depressor anguli oris, which depresses and moves laterally the commissure by the buccal and the marginal mandibular. The zygomaticus minor or major elevates and moves laterally the commissure by the buccal and zygomatic. The second group, which insert in the upper lip, are the levator labii superioris, elevates the lip by the buccal, all of them. Levator labii superioris aliquinizae, dilates the nostrils of the nose and elevates the upper lip. Zygomaticus minor, which elevates and pulls the commissure laterally. That is by the buccal. The third, which insert into the lower lip, are the depressor labii inferioris, depress the lip and slide laterally by the buccal and the marginal mandibular. The mentalis muscle, which deviates the lower lip. And lastly, the platysma muscle, which is a very important muscle in the neck. When we come to the neck, it depresses the lower lip, supplied by the marginal mandibular and cervical. The nose muscles are the nasalis, which compress and dilate by the zygomatic and buccal, the other two by the buccal. Depressor septi, which was not seen here, but this one is the levator labii superioris aliquinizae. That is the summary of the muscles, which you can know the names only and some of the actions. When it comes to the nerve supply of the face, supplied by the ophthalmic division of trigeminal, this is the trigeminal nerve, and this is the area supplied by the ophthalmic on the face. Maxillary, and this is the area supplied by the maxillary. Mandibular division, and this is the area by the mandibular. And the second cervical, the great auricular nerve, supplies the area around the angle of the mandible. That's a very important point to remember, that the great auricular supplies the area at the angle of the mandible. So the face is supplied all by the trigeminal except that area around the angle of the mandible. And this is very important when you are going to diagnose the case at the level of which nerve injury is, at the level of the cranial nerves or at the level of the spinal nerves. To summarize the nerve supply of the face, the sensory, as we said, branch of trigeminal nerve, except that area covering the angle of the mandible, by the great auricular, which comes from the second and third, but this area is from the second only, supplied by the second cervical only. So from the ophthalmic division, the branches which will reach the face are the supratrochlear, supraorbital, palpebral branch of the lacrimal nerve, infratrochlear nerve, and external nasal. As you can see, we are taking those nerves from the terminal part of it, the term branch of them, of all the cranial nerves will be studied again, starting from its origin down to the distribution. So we'll repeat what we are saying now. Mandibular division by the mental nerve, the buccal, the auriculotemporal, the maxillary by those branches which reach the face, the zygomaticofacial, zygomaticotemporal, and infraorbital nerves. The motor by the facial nerve, the 5 branches of the facial nerve, supplying all the muscle except the small muscle called the levator palpebrae superioris, which is attached to the upper lid or move the upper eyelid, and it's part of the muscles of the intraocular, the muscle found extrinsic muscles of the eye ball. We'll come to see it. Here, the facial nerve, which innervates the muscles of facial expression, as we said, it comes out from the skull through the stylomastoid foramen, enter the parotid gland where it divides into its 5 major branches. The temporal branch, which is this one here and here. On the right side, this is a cadaveric specimen, well dissected, and this is a diagram on the left side. So you got the temporal, the zygomatic over here on the left and on the right, the buccal on the left here. Actually, there is an upper buccal and lower buccal, upper above the parotid duct and lower below it. So these are two, the buccal. What you can see here is the lower buccal. The upper buccal is this one here. The marginal mandibular along the mandible, along the edge of the lower border of the mandible. And lastly, the cervical branch over here. But it gives a posterior auricular branch behind the auricle. That is the one which supplies the occipitalis and the muscles of the ear. This is the facial nerve. The arterial supply of the face supplied by branches from the external carotid and the internal carotid. The branch from the external carotid artery are the facial on the right side here, and the specimen, cadaveric specimen here, and on the left side. Superficial temporal over here from the upper end of the parotid gland, and this superficial temporal. The maxillary artery, which is shown only on the left side. The buccal branch of the internal carotid are the ophthalmic, branch of the ophthalmic artery. Here is branches of the external carotid again, which are the facial artery on both sides. From the facial artery, there is the inferior labial, the superior labial, and the nasal. From the superficial temporal, there is the transverse facial artery, this one here. Zygomatic-orbital, this one here. Middle temporal, this one here. Auricular artery, this one, the small one on the left side. From the maxillary artery, this one here, which is shown only in the left side. The infra-orbital artery, a very large branch, and the buccal artery. The mental artery. Now, the branches of the internal carotid, we said that is the internal carotid here in the cranial cavity, which give ophthalmic artery passing through the optic canal here to reach the eyeball, the orbit. It will give this ophthalmic supratrochlear and supraorbital, a lacrimal branch which will divide in these two, a medial palpebral arteries and lateral palpebral arteries, and external nasal artery. These are the branches which reach the face from the ophthalmic artery. The venous drainage of the face and scalp together. There is supratrochlear and supraorbital veins will unite to form anterior facial vein, while the maxillary vein will unite with the superficial temporal vein to form what we call it the retromandibular vein. The retromandibular will divide into anterior division and posterior division. The anterior division will unite with the anterior facial to form what we call it the common facial vein. The posterior division will unite with the posterior auricular to form the external jugular, which will end into the subclavian vein, while the common facial will end into the internal jugular vein. That is a summary of the veins of the face and the scalp and the behavior of both of them. That is some diagrams showing those veins here. The anterior facial vein is this one and this one here. And as you can see, the anterior facial vein communicates with the superior ophthalmic and the inferior ophthalmic veins. And through this communication, the facial vein communicates with the cavernous sinus inside the cranial cavity. The importance of this is that infection can be transmitted from the face, where an area, we call it the dangerous area of the face, which come from the angles of the nose to the angle of the mouth, mainly. And this is a very serious illness because it can affect the very soft and important structures within the cranial cavity. Also, there is the pterygoid plexus of veins here on each side, and this plexus connected again to the face and to the cranial cavity, to the cavernous sinus. The danger of this fossa, of this pterygoid plexus here, is that it drains the nose, the mouth, the pharynx, so the mouth cavity, the nasal cavity, and the pharyngeal cavity. Infection from the teeth, from the nose, from the mouth, from the pharynx can easily transmit it to the cavernous sinus, which is again a serious condition. The lymphatic drainage of the face and scalp. Here it forms a circle starting from that point to that point here, and vertical lines in the neck. So the occipital, the posterior auricular, or the mastoid, sometimes called the mastoid, the parotid, which are two groups here. This group, the upper one, sometimes called the buccal, and this goes to the upper deep cervical. To complete the circle, there is the submental and the submandibular, and all of these groups will end in mainly the upper deep cervical lymph nodes here. That is all about the face and scalp.